Good morning, everyone. Our next presenter is Stefani D'Angelo. She is a clinical researcher, manager at the Institute of Health System Science with the Feinstein Institute for Medical Research at Northwell Health. She specializes using commercial health devices and text message-based data collection to conduct virtual and N of 1 clinical research studies. She is currently a master's student studying health informatics at Hofstra University. Without further ado, Stefano D'Angelo.
Hey, thank you so much. Can everyone hear me? Wonderful. It is a joy to be out here this morning. I thought this actually might help not have to carry something, but apparently women's jackets don't have pockets, so we'll power through. This is my first time giving a presentation out in the real world in I don't know how long, so it's a joy to be with you guys here this morning. I'm here to talk about technology and how we can use it to redefine health research so that we may never need to go out in the real world and kind of do things, but still be able to present high quality data. Do we have, is this the clicker? Am I missing it? We'll just do this. I co-developed this presentation with my colleague, Dr. Ciarán Friel, who unfortunately was not able to make it this morning as much as he wanted to be here. I will do my best to convey his vast knowledge in this space. I'm probably not going to do as well with his Irish humor or Brooklyn humor, but we'll kind of power through. Don't worry, at the end of the presentation, we'll have his email address. So if there's anything that I say in the next few minutes that you disagree with or have issue with, feel free to start drafting that email to him. He'll be on standby. But as mentioned, my name is Stefani D'Angelo. I'm a senior clinical research manager at the Institute of Health System Science with the Feinstein Institutes of Medical Research at Northwell Health. It is a mouthful to say, but it's a really amazing job getting to work with wonderful investigators like Dr. Friel to really push the boundaries of what we're able to do with healthcare research and really push the patients and comfort of our poor legal and IT security teams. But we really believe strongly that it has the potential to change our approach of how we look at creating wellness for our patients and our communities. This might work. Perfect. So this morning, we're going to start talking about the current health research landscape and how it's changed over the past several years, who we are at the Institute of Health System Science and our experience running some of these studies, some tips and tricks from what we have found out over the past several years, and some sort of indication of where our research is going next. So what do we mean by redefining health research? Many of you are probably familiar with this evidence-based pyramid where we have kind of lower quality data at the bottom. As you kind of get to the top of the pyramid, it's more rigorous data, more evidence-based with meta-analyses and systematic reviews of randomized controlled trials are gold standard of evidence-based care. Randomized controlled trials are wonderful. They can also be long and expensive and not very flexible once you have that protocol established. And when I mean long, I really mean long. There are some estimates that it takes about 17 years for research to go from randomized controlled trials to evidence-based care. And in some cases, as little as 14% of kind of research insights that we gain actually ever make it to that research care space. What you may not know that as researchers, we talk about this evidence-based pyramid, knowing that it's not really telling the whole story, and particularly when you're thinking of what is the best evidence-based option or treatment option for an individual, their randomized controlled trials may not be it. In fact, if you were to look at textbooks back from the 80s, that top of the pyramid would be replaced with something called N of 1 trials. And in the 80s and 90s, an investigator, particularly by the name of Dr. Gordon Guyatt, he did lots of research on N of 1 trials and how we might incorporate it into the clinical space. Ultimately, he determined that it wasn't feasible, and it basically fell off the pyramid, and randomized controlled trials have remained supreme ever since. But with advancements and new emerging technologies that are coming out, that may not be the case anymore. New technology may enable us to get better data, maybe even faster than our randomized controlled trial. It may enable us to have different types of study designs at our disposal. Things like genomic sequencing, digital analyses, machine learning, they're really creating new potential for us and how we approach research design to collect data. We have things like adaptive trials. Those are trials where you continuously collect data on certain participants, but the details of the number of participants in that arm or the characteristics of what that arm is itself may change based off of the data that you're collecting from previous cohorts. So as an example, we have an adaptive trial that's coming up with medication adherence and statins. And so basically the dose of statin or time that an individual gets changes based off of the data that we see in those who complete the trial before the participant is enrolled. Kind of at the opposite end of that a little bit is an N of 1 trial, which we talked about a lot. I'm going to try really hard not to make this an N of 1 presentation because that's kind of most of my portfolio. My bread and butter is working with N of 1 trials. But the sense of that is it's a entire randomized controlled trial that takes place in one individual. So we're not necessarily concerned with, is this treatment working? Is it not working? We're concerned with, is it working for this individual? And kind of at the opposite of adaptive trials, we don't care what worked for someone before, we kind of care what works for you right now. Real world data from computerized systems like electronic health records and insurance databases and many other types of information allow us to take millions of data points and get really cool real-time insights. Things like the Google Flu Tracker, if any of you are familiar, take search queries of the flu and influenza-like illnesses and plot them. And basically, it's being used as a surrogate for clinical reporting of flu around the world. Similarly, things like the Strava physical activity heat map, updated monthly, showing physical, behavioral patterns across the world, are great examples of how real-world data and computerized records are being used to give us better understanding of what's going on. Master observation protocols are very similar, but they typically have some predefined kind of set protocol that's followed through with that real-world data collection. And it's really cool to think of kind of where we started really not that long ago, that the initial, Fitbit that you strapped into a pocket that you don't have if you're a female wearing a blazer, not better, we're gonna get through this, that had a little docking station that would connect to your computer in order to upload the data, that wasn't connected to a smartphone, that wasn't all of that reliable, could eventually turn into technology that's being considered to be a medical device. In fact, in a little bit, I'm going to tell you about one of our research studies that's using the newer models of the Fitbit, so the Fitbit Versa 3 or the Fitbit Sense, to potentially predict COVID-19 from very slight physiological changes in the data that's picked up by machine learning algorithms. And then we even have things like BioBeat, which is considered a medical device, and it's being used by healthcare institutions like Northwell in ambulatory care settings, and has the potential to not only collect all of this data, but set alerts to care teams that might help tip off whether someone is entering a deteriorative state, if they need to, come back post-discharge, or if they need to kind of come in quicker than scheduled. And kind of looking ahead to where we're going in the next, immediate future, we're asking ourselves questions like, can wellness data be added to the electronic health record in meaningful ways? So things like the TechnoBench, the Peloton, the Tonal is really giving us new insights into data that we didn't really know how to get in a valid way, easily, remotely before. Things like resistance training, intensity, and what that could potentially unlock for a overall wellness or care plan. And not only are we getting new insights from different types of data with new technologies that are coming through, but they also have the potential to relieve some of the burden that's normally seen with clinical research studies. So, these cloud-enabled devices, consumer devices, automated systems have the potential to relieve burden both on the researcher end and on the participant end. On the participant end, it's really lovely not being able to have to physically come into a location to have your data tracked or collected. You don't have to live near an academic medical center in order to be part of the research process. So there's reduced burden there. We might have a greater reach as far as the research itself to get different types of populations with different geographic diversity, races, ethnicities to be a part of our research. And then other ways it reduces burden on the researcher end, we can focus less on research assistance and data entry into things like REDCap and have data flowing automatically into a database. We can have automated systems send out schedule reminders of upcoming appointments or send out protocol nudges to, hey, like, take your medication now, to relieve some phone calls or emails that have to be done on the coordinator end. And it gives us the great ability to do this all from our pajamas at home if the last 2 years have been any indication of how we might be able to use this technology. More so, I think the technology is also giving us better data, both in the sense that it's more reliable. So self-report data is notoriously biased from participants. So if you can slap a Fitbit on them and have them go about their day, we're much more confident in that data that's coming in. But it also gives us more data points. So if you're someone like me, I understand healthcare, I understand, primary care and its importance. If I walk anywhere near a hospital, even to give a presentation, like I'm sure blood pressure just seems to go up. If I take it at home, most of the time, if I take it at the workplace as I'm commuting, it's completely fine. And we know this is a problem in healthcare, that sometimes we have this, these episodic events that may not be reflective of a person's entire day. One little example from some of our N of 1 studies that I love to give as an example for this as well. We had a participant in an early pilot for N of 1 study. It had to do with stress, but we went ahead and sent a slew of devices home with her to track over 2 weeks, including a air pollution monitor. It's called the Flow by Plume Labs, if anyone is familiar with it. She strapped it onto her purse. We followed it around for 2 weeks. Got all of that data back. And when we were looking at it, if you were to just look at where she was geographically throughout the day, her workplace in Manhattan, her home outside of the city, the air quality was pretty great. I mean, it was fine, even for a city. But there were these 2 blips on the map that we couldn't really figure out 2 days. And it happened around a commute time, but it wasn't every single day. And so we had no idea what to make of it. So when we discussed the results with her, we were able to determine those were the days that she took the old family car to the office, and it wasn't, the newer car. And as we dug a little bit deeper, she took the car to the mechanic and found that her husband, who had been in charge of oil changes for that car's life, had kind of skimped out on the air filter change, never elected to have it. And when the mechanic brought it out, it was absolutely filthy, horrified this participant. Her husband got into so much trouble. And when they got a new air filter in, she actually found that it relieved some of her symptoms of headaches that she was attributing to stress. So a great example of how more data in unexpected places can lead us to things that we may not have thought to look for in the first place. So I've mentioned a lot about remote, digital, virtual trials. What does it all mean? They're all very much buzzwords in the healthcare space right now. Pretty much we're looking at 2 things in particular, basically what data is collected, where it's collected, and how is it collected. So is it collected in a workplace? Is it collected in an academic medical center? Is it collected at home? Is it collected from your smartphone? Is it collected from a survey? Is someone calling you and putting all of this information into a system? And it really delivers this full spectrum of what we have at our disposal for decentralized clinical trials. So anything from the spectrum of fully centralized, which is our kind of typical traditional come to an academic medical center, come into our office for a full workup by a research assistant, and then don't call us, we'll call you with the results type of thing, to fully decentralized where you never leave your home, you never leave your apartment, and we're able to get all of the data that we need. And at our Institute of Health System Science, we do a little bit of everything, and we'll kind of talk about this is our tool belt, and that concept of, when you have a hammer, everything looks like a nail, kind of when it's best to kind of deploy each of these types of research designs. All right, so now that we've kind of laid the groundwork of what do we mean by kind of our current state of health research, I'm going to go into more information about the type of research that we do. So the Institute of Health System Science is a multidisciplinary team. So we're made up of clinical psychologists and behavioral health experts. We have exercise scientists, we have clinical investigators, we have usability lab and implementation specialists, we have data scientists, we have statisticians. Honestly, I've stopped trying to keep up with everyone that we have. I just smile whenever I join a Zoom meeting. But the whole point of gathering this multidisciplinary team is to put together these different perspectives to take a look at how we may take the basic research that's coming out and the new insights and the new information that we're uncovering and apply that to system science. And really, more so than anything, try to cut down on that 17-year timeline to get more immediate, like, so what, how does this apply out in the real world environment? And one of the ways that we do this is through a concept that we're a little bit obsessed with, if I can say, heterogeneity of response. And so the randomized controlled trials we've already talked about is our gold standard of research, and a positive randomized controlled trial, the results of it typically fall on a bell curve. I'm going to pause. This is going to be a little bit of an oversimplification, but bear with me. You can start drafting your email to Ciarán. It's fine, but I think we'll get there together. We'll make that point. But bringing it back, a positive randomized controlled trial just has to work in most of our population, right? So in this example, a little bit over half of the people see benefit, and that's wonderful. Yay us, we did it. This treatment works. Let's move on. And it's a wonderful way to approach things, to find what works and keep trying to find things that work. But the thing that kind of keeps us up at night that we're obsessive about is, what about those people who have a neutral effect? So the treatment doesn't necessarily hurt them, it doesn't help them either, they're unchanged. And what about the people who actually experience some harm for whatever reason? That blood pressure medication increases their blood pressure. What is it about them? What is it about their phenotype? Like, what sets them apart? And so these are the places that we tend to obsess over through things like N of 1 trials, adaptive trials, more traditional research, to kind of focus on the people that it's not working for, and can we explain why? And does this unlock potential for a greater understanding of how we approach clinical care and wellness? And so how we do that focusing on the outliers requires a different approach than traditional research. So a lot of our research is done remotely, hybrid. We use things like social media, QR codes, text to enroll, like text COVID to 12345 to enroll in the study. That is not one of our codes. Please don't text COVID to 12345. But this is how we basically find people to enroll. Once they get there, we'll do screenings. We'll give them some informational videos of, here's what is meant by this study. Here's what your activity is going to be. Here's what's expected of you. We'll go over the informed consent form electronically. We'll enroll them in a text message-based system that will send them surveys, and we'll walk them through every step of the protocol. A research assistant will mail them a box of various devices that they'll need already set up to be able to participate in the research. We'll send them text message prompts throughout the day saying, now it's time to take your blood pressure medication, or now it's time to go for that walk. We use commercial devices mostly, things like Fitbit, Apple Watch, blood pressure devices like the cardio, continuous glucose monitors like the Freestyle Libre, medication adherence devices to see when a pill bottle has been opened and closed. In conjunction with surveys, we rely heavily on ecological momentary assessment, which is kind of our more of our gold standard of, instead of asking someone to recall how they felt throughout that day or throughout that month, how do you feel right now? And if you ask them enough times, you'll get a good sense of their day. We have research assistants that are remotely monitoring all of this adherence, and they're able to see, okay, Is something wrong potentially with your device? Did you take it off? Are you not taking your medication? Did you take the wrong medication? We have data analysts who begin analyzing the data as soon as it comes in. Once we have all of that data, we provide a report back to the participant that explains what we observed back to them, like that one participant with the air quality in her car that was so terrible, to let them know that, like, hey, we're still looking at how these results apply to a more general population, but for you, here's how it goes. And we kind of go on our way with the different trials. And not to brag or anything, but we've been pretty good at it. So I mentioned our Fitbit study that we have going. It's actually still going on right now. It's going to continue until July. We have about 1,500 Fitbit devices that have been deployed in healthcare workers to monitor COVID-19. And that is a fully, well, I would say it's a hybrid study. So basically, it's 8 to 18 weeks, depending on kind of where a participant is. They'll go in for weekly lab testing, and then as our algorithm became more refined, we were able to make it so they are only sent for lab testing if the algorithm thinks that something might be up, there may be changes in their data, and they're able to go to any lab site that is convenient for them, that's by them. We also had a study, that second point, it was an N-of-1 study of participants with chronic lower back pain, looking at non-pharmacological ways that we may address that chronic pain, namely with massage and yoga. And so we partnered with a company called Zeal. They're a technology-based wellness company, to send massage therapists or yoga instructors to an individual's home or wherever they wanted to be able to participate, do the interventions twice a week for 14 weeks. As you can imagine, that was a very popular study of ours, had no trouble recruiting for it at all. I would consider it a reminiscent of kind of home health. It wasn't necessarily fully remote or fully hybrid. We had people going to the individual home, but it ended up working out really well for a couple of reasons. One, if a participant had to travel, say go to Texas for a conference, they could book with Zeal a massage therapist or a yoga instructor in Texas and not have to worry about missing one of their assigned treatments. This also kind of happened during COVID. COVID interrupted our study halfway through. And so when we came back and were able to participate in non-COVID research again, participants were able to have the massage or yoga sessions wherever they were comfortable. So we had people doing it out in Central Park. We had people going out in their backyard and getting massages. We had people going in parking lots and doing yoga, really whatever worked for them in that moment. And this last example is another N-of-1 trial of fatigue using light therapy to address symptoms of fatigue. And with that, we were able to enroll participants all across the United States and got a representative sample from all time zones in the 48 contiguous states. And not only has it been working, but our participants are actually really loving it. So these are some direct quotes taken from some of our follow-up interviews. We found that, although being easy to implement in your everyday life, we're also getting pretty great adherence. So even studies that have up to 4 or 5 text messages, surveys that are sent a day, we're still seeing rates of 85% adherence or higher for a lot of our studies. So this is the part where I'm going to stop and be like, how am I doing on my sales pitch? Are we convinced that technology and these decentralized research opportunities have great potential for us? We're saying, yes, Steph, sign me up. There are no downsides. There is no catch. This is the future. I would love to be able to tell you that, but for the next little bit, we're going to kind of talk about all of the catches that we found most significant in the last few years of our research. And things that you may want to consider as you think about implementing technology-based trials or fully decentralized virtualized trials, or even programs at your site. So for one, it's pretty complicated, and that's putting it mildly. This is a sample data flow from one of our projects. And as you can see, we have several different types of databases that exist that are collecting partial data for data security reasons. So if you were to go to any one of these places, you would only get a portion of the story. And in order to be successful with implementing this, we have to find a way to tie all of this data together in a method that is secure, that is valid, and that's not going to easily break. So a couple of things that I'm hoping you're asking yourself, where do you store all this data? You know, even thinking of something like SIPIT, we're not talking about a couple of surveys that might be sent from REDCap, right? We're talking about minute by minute, sometimes data every single second that comes in of their heart rate, their intensity, their steps, their sleep. And when you start having studies up in the thousands and some of these mega studies, it's a really huge consideration of where does that all go? Important, and then also very important, how is it safely secured? And so in thinking through data management and some questions that before you begin, you should be able to be really comfortable with. And I will say that, you know, a part of this is being able to explain it to regulatory compliance people, to IT security people, to your database architect, and visuals usually help a lot, so highly recommend. But first and foremost, is your data valid and reliable? How can you even check data integrity if everything is remote? So for example, with our Fitbit study, we send people to a lab. If we don't get a lab result, does it mean that the participant never went for their lab? Does it mean that they went for the lab, but the person who did the lab draw forgot to send it in to the core lab site for analysis? Does it mean that the core lab site dropped the sample and they weren't able to process? Does it mean that there was a delay and we just haven't gotten that data back? That's been many examples of many questions that we've asked ourselves as we're looking at this data remotely, because as you do things virtually, you lose that context of what's happening at any given time. How are you going to aggregate that data? Do you need a cloud-based data collection system? And if so, do you have the funds for it? That can also add up pretty quickly. We're moving away from doing things like purchasing servers and more into a space of subscription-based services. So as you grow, do you have the technology to scale with you? We've already talked about are you going to store your data and is it secure? And how are you going to clean and process that data? How are you going to account for missing data? So that's also a huge part. I can't tell you how many conversations I have a week about missing data and what we're going to do if a participant took off their Fitbit for a week and a half, or if we try to give a treatment but they miss it by a certain window. Does intent to treat still work in these situations? Are there ways that we can use algorithms and statistical analyses to estimate, and does that ruin some of the integrity of our data? All important questions that we don't necessarily know the answer to, but are important considerations as you're building out. Another downside, I know we talked about how technology makes things less burdensome, but I'm also here to tell you that it doesn't make things less burdensome for everyone. You may be familiar with the Gartner Hype Cycle for emerging technologies. So the idea behind this cycle, this chart, is something like the new MacBook comes out as our innovation trigger. Everyone gets super excited, and there's this peak of inflated expectations of, I need to find $1,500 to drop on this MacBook right away because it's going to change my life. It's going to change the way that we approach data collection. You go, you buy the MacBook, you come home, you realize it's basically the exact same thing that you have, only now there are different ports that have changed, and it doesn't work with some of your technology at home, so you have to go out and buy more ports and buy different technology to use to integrate with that system. So you get to your point of disillusionment, and then as you're using it more and more and more, you think, okay, well, the processing system is kind of better on this, and I do like it. And you go up your slope of enlightenment until you find your plateau of productivity. And then it all starts again whenever they announce that next version at the Apple's conference, right? This really spoke to me with technology and virtual-based research, because I see it, and I see it in every aspect of things that we do. So at any given point, part of our research falls in any area of this graph. And I was very fortunate before I worked in the research space to have some experience with app building and technology creating. So I approached the role with, oh, I know not to have inflated expectations. I know how this is going to work. Things are going to go up, they're going to go down, but then we're going to level off at a certain point of productivity, and we're going to be able to make it work. Boy, was I humbled. So I'll kind of get into the graph in a little bit, but some considerations of expectations versus reality, even when you think you know what to expect, particularly with the healthcare space, the health research space, health technology. The playing field is constantly changing, constantly changing. By the time you receive your agreement from legal to sign that contract, to purchase the device, by the time it goes through your IT security assessment, to be able to use it in a healthcare space, by the time that you work with your developers to build out a way to automate those features and to build out a way to pull in that data, guess what? Your technology is obsolete. There's something else out there that's newer, better, faster that you haven't accounted for. Not to mention that regulations are also constantly changing, especially right now. Things like electronic signature, huge hot topic. The UK several years ago put out GDPR, and that really changed the way that we think of a lot of technology-based data collection for overseas. But California quickly adopted something similar, and New York is discussing what our version of GDPR is going to be in the future as well. So, it's very possible that all of the stuff that we're currently building is going to, in a couple of months, in a couple of years, with an announcement, be deemed non-compliant to be used in the healthcare space, and we're going to have to go back and make changes. So what I can say to that is make friends with your regulatory experts and engage in conversations. By all intents and purposes, they could be best guesses because we don't know how these regulations are going to change, but when, but they won't completely catch you off guard. One other piece that I am absolutely fascinated about in my studies with health information technology is the complete separation of ideology between those who develop technology and those who work in the research space, right? Those who develop technology, it's an agile method, fail fast, fail forward. We want to break it. We want to learn how we need to fix it. We want to build it up better. Healthcare is not like that. Healthcare is, hey, let's take 17 years to retest this research, right? And then be able to say, yes, for sure, this is our gold standard. For sure, this is our evidence base. This is what's most secure for our research patients. So how do you marry those two together? It's very difficult. The other part of it that I find just absolutely fascinating is, although developers have an agile approach, I kind of consider the opposite when it comes down to statement of work and figuring out how you're going to pay for technology building, especially if you don't have developers in-house and you're using vendors. So while we love agile methodology in the development space, we also love a clearly defined project start and project end. And we also love clearly defined expectations of what exactly are you going to need. And research is not like that at all. Research is, let's do small pilots of this for the next 6 months and figure out what needs to change. And then as we're talking to individual people through your N of 1 studies, make incremental changes at a time. That frustrates the heck out of developers because you're constantly moving the goalposts for them. And even though with all of the advances we've made in technology the past 10 years, 5 years, 2 years, consumers have varying levels of comfort. And I wish any of this I'm about to share with you is an exaggeration, but 2 very real conversations I've had recently. One, a participant called asking what their Wi-Fi password was. We were trying to set them up with a Fitbit device, and I spent an hour and a half on the phone with them on a Saturday, trying to walk them through a house I have never been to find their router, praying to God that the router had a sticker with their Wi-Fi information, their Wi-Fi password on, so we can connect their Fitbit to a Wi-Fi connection, and we can get them to get the data that we needed for the study, right? On the whole opposite end of that, I got a call from a very irate patient that our automated system wasn't available to answer their question at 3 a.m. during their shift work whenever they needed help. And it's probably the strangest conversation I've ever had with a human being to try to convince them that we are not robots, that we are people who sleep. But the expectation was, oh, all of this is virtual. You must have a bot on the back end that's answering these questions. And very much it was just a poor research assistant who got yelled at. So that was a fun conversation as well. So kind of going through back on this graph, the blue is really what I was expecting when I entered the role, is that there would be, some sort of peaks and valleys, but we would eventually get to a place where we had the technology to where it would plateau for a little bit. We'd figure out how to use it. We would go through the process again and, make our incremental change, plateau a bit, make our incremental change, and it would all be good. Reality has been very, very different. And if Ciarán was here, he'd probably say that the green portion of the graph is probably a little optimistic of me to have the arrow even going that high at this moment. But I think it's very representative of peaks and valleys. And sometimes, you know, you build something, you get it to a place, you think, yes, I'm finally making it. And then that playing field changes and you realize that everything that you created obsolete, is no longer able to work. And sometimes it actually feels like you're moving backwards in time. So all fun considerations, really the reality of kind of working in this innovative space. And another important downside is there may be unintended costs. We're not even scratching the surface at the moment with actual costs of building out some of this technology, building out some of these platforms. We're very fortunate to have funding from the NIH, particularly to look into N-of-1 platform methodology, and is this something that we could scale for the future, and can we create resources to make it easier for people to implement these types of trials? But there may be some human costs as well. So while connected care can bring assistance to underserved, and a statistic that I'll throw out in every single meeting with an IRB is 70% of the world has a smartphone. And that's not even considering the United States, right, and developed countries. And so most people have a smartphone and they can use this technology. But are there unintended ways that your technology is creating barriers? And so I think these are always important questions to ask in everything that we do. But I think an important learning I had from that back pain study that we did with N-of-1, like I mentioned, we had absolutely no trouble recruiting for a study that gave free massage, free yoga twice a week in home or wherever you wanted it to a participant. But our research assistants were noticing that some people would be really excited about it, and then they would find out the details and they would say, oh, no, that's okay, I can't do that, like, no, thank you. And fortunately, you know, we work with really great research assistants who engage in really meaningful dialogue and ask good questions. And we were able to find out that we were unintentionally creating a barrier for people who live in multifamily homes, and that not everyone can set up a table in the middle of their living room to have a massage or to have a safe space to do yoga. And so while we prided ourselves on really designing this entire study around the idea of participants never going to a place to receive their treatments, because we thought that's what would create the best access for our participants, we had to flip it pretty quickly on its head and start going back to more traditional methods so that we would be able to be inclusive of anyone who would want to join our study. So what we ended up doing is partnering with wellness-based centers kind of all around our catchment area, so Manhattan, Long Island, Connecticut, New Jersey, to be able to rent out rooms so people could schedule their yoga or massage sessions in a location, a physical brick location that was convenient for them. So some best practices in all of these things that we've talked about. In planning, oh, that's strange. Those were check boxes, not cues at some point in time, but gotta love technology. In planning your tech-enabled trial, you're gonna wanna start early, you're gonna wanna start small, you're gonna wanna pilot the heck out of anything, especially if it uses the data. And really go in it with the expectation that you're probably going to be more frustrated with it than you are excited that it has the potential for the future, right? But what I constantly tell myself and those that I work with is that if we're not struggling, if we're not failing, we're probably not doing something right. So take it as a good sign that you're probably on the right track if it's very hard. Don't be afraid to get into the data. So one example that I have is in never assuming that you're speaking the same language as someone, especially as a developer. We, for our N-of-1 platform, one of our main concepts that I discussed with them, I don't know how many times, is that we need to be able to send ecological momentary assessments at random times throughout the day. So I need to have a participant when they wake up, have their wake time, when they go to sleep, have their sleep time, and then at 3 random times in between that window, send them text messages throughout the day. Developers are like, yeah, we got it. It's random inherently by nature. And when we were testing it, it wasn't working. And I was getting so frustrated. Like, we talked about this. Why isn't this happening? And the developers were getting frustrated too, saying, no, it's random. So we pulled the log and we saw that they did program the computer to send it out at a random time between, say, 8 a.m. and 10 p.m. But in the computer, to the computer, that meant send out all of these messages at any given time between this and this. But the computer wanted to get rid of its tasks basically as quickly as possible, oversimplification. So it would send everything out at 8 a.m. because it had the processing time to send that information out right then. And there were no restrictions to stop it from all going out at one time and try to spread it out evenly throughout the day. So that caused an unintended delay in our project because we really had to define what it means to even randomize, something that I took for granted as being very simple concept, to build out to be able to program into the computer, what does randomization actually mean? Having really hard, long conversations with yourself about what data do you actually need. So we talked about data being immediately obsolete at the time that you use it. It's very hard to resist seeing that shiny new object and saying like, oh, VOT max, we need that. We need that in our studies, let's go build it. We've learned that just because you can doesn't necessarily mean you should. And there is no better way to drive the cost of your project up or to extend your timeline than to consistently be adding data points that you don't necessarily have a plan for. Because as researchers, we know like, oh, at some point in time, I might want that data. So like we should have it. We should have it just in case. Have conversations about what is going to be clinically meaningful for you and your patients. You know, I approach everything kind of like I do with investments of there's risks, there's rewards. What am I able to bank on for that long-term investment? But we're not doing any day trading here with creating our technology platforms. And then have these digital endpoints been validated, well incorporated? Is there a chance that Fitbit's going to be obsolete in a few years? Like, yeah. Are we taking that chance right now with where we're building our technology? Yes. And that's just something that we have to be comfortable with. And then in thinking through what device that you should use, has that device or software been previously used in research? Has anyone else been able to demonstrate success? If yes, great. If not, also great, you know, getting into an innovative space with these different companies, but temper your expectations a little bit and plan to, you know, struggle along the way. It'll just make you happier as you go through your journey. Have a full understanding amongst your team of how are you using this technology? Is it purely to collect data? Are we trying to change behavior with it? Are we trying to do something both? Because sometimes we create competing priorities with the technology that we're creating. So as long as we're on the same page with how we want to use it, we can be more intentional in the design behind it. And test the technology yourself. Do we think at the end of the day, once everything's done, that a participant's actually going to want to use this and that a participant is actually going to be happy and incorporate it in their daily life to eventually get into our outside of the research world to get into clinical practice, because that's our goal at the end of the day. Questions to consider when planning to automate. Why are we automating this? Again, when you have a hammer, everything looks like a nail. It's very cool to say like, oh, decentralized, virtual, I can work from my pajamas, this is great. But what we found is automating things doesn't necessarily remove burden or doesn't necessarily make things easier. Sometimes it's easier just to do it the old-fashioned way, and it's faster to get the data that way as well. So have those conversations of, will this actually be a game changer for us if we were to go through and develop new technology for it? What risks will we incur if things fail, when things fail? They're going to fail. And what is our contingency plan when these things go wrong? Am I very clear on what data needs to be collected? Developers, data architects, they are not researchers. So can I explain everything in a way where someone from Silicon Valley is going to understand that and it's going to be meaningful to them? Again, pictures, charts, graphs, those are the ways to go. And all of this kind of leads to what is our minimum viable product? Like at the end of the day, what is the very least that you need of your technology, of your database, to be able to be successful in what you're testing out? So wrapping it up, key takeaways. This is really Ciarán's slide. I left it in it for him. Or his little Thomas Jefferson, with great risk comes great reward. Couldn't agree more. There is a lot of risk associated with it. And I know those downsides we talked about were pretty big bummers, but it is worth it. And we really strongly believe that. Just because it's hard doesn't mean that you shouldn't try. You should just go into it with open eyes of exactly what you're getting into, so that you can be intentional and slow in your design and test it and retest it to make sure that you're confident that this is actually going to make a difference for your research and for eventual clinical care. Understand your requirements. Exactly what do you need, when, from where, how, roll up your sleeves. Even if data isn't your thing, programming isn't your thing, it'll relieve a lot of issues along the way if you're there constantly. New technology often costs a lot and quickly becomes obsolete. Sometimes it's worth it to avoid the shiny and to go with something a little bit more reliable to get your studies done. And don't over-expect. Plan to, like I said, plan to fail. If you're failing, you're probably doing something right. And where we're heading as an institute, I mentioned that we do a little bit of everything. So some studies that we have coming up in the next several months or so kind of run the whole range of scope from your traditional in-person studies. We have a dementia identification and support project that is in clinic with an iPad, following around clinicians, trying to get them to be better at dementia screening, all the way to more remote activities like behavioral change techniques and activities, and how we may be able to use prompts and things like a Fitbit device to understand the mechanisms of action behind behavioral change techniques to increase activity in sedentary adults. So a whole sleep quality, stress management, activity, alcohol, and cancer. We find very different ways. And I think the point of this slide is that our plan is a little bit different for each one. And even though we have the technology and the resources to make all of these decentralized, it doesn't make sense for what we're trying to achieve and what our outcomes are for these studies. And so it's really, think of it as a tool belt of what are your strengths and what are your weaknesses and what are you trying to achieve before you kind of set a study design of being fully remote and decentralized. And our overall goal is to kind of connect these disparate pieces. So success in our eyes in the next several years is how do we collect data from these commercial devices, from these wellness-based devices on resistance training, on activity, on heart rate, and be able to create research insights and create, algorithms and different packages that create meaning out of those insights and provide them back to clinician care teams, doctors, their physical therapists in meaningful ways that can address a care plan and a wellness management plan that will utilize technology that will further feed this cycle. And so this is where we hope to be. And with that, I thank you for your time. Are there any questions? Yeah.
Thank you. So quite a delightful presentation. I would like to commend you on your command of your material and your delivery. I have a quote I'd like to share with you, and then I'll have a follow-up question. And the quote is from Robert Neil Butler. I'm guessing a lot of people in the audience are familiar with it. If the benefits of exercise could be provided in the form of a pill, that pill would be the most widely prescribed medicine in the world. So from there, of the technology that we have available, could you talk to us a little bit about which technology has been most effective in helping people either begin exercise or do more exercise and do the right amount of exercise?
I really wish I had an answer to that question, because I think I'd be a very rich person if I could say, this is definitively the answer. And I'm a little biased in that most of my research kind of focuses back on that heterogeneity of response and the idea of it's going to be different for everyone. And we really need an approach that's more N of one. And we really need to have the technology and the resources to engage an individual in that decision-making and that planning to really figure out what's going to work best for them. So we've had some, even that yoga and massage study, we've had some people who they went in it and they were like, yeah, I'm doing this for free massage. Like they told us, this is why I'm here. And I get it, like that's like you and your prerogative. And they had the yoga at the end. We asked them, hey, what are you going to select, they're like, massage, obviously. If I only had $100, a week to get this massage done. And then we showed them the data. And we said, this was great. This is how you acted with massage. You saw great benefits in the next 24 hours. But look at this data from when you did yoga, and look how sustained it was, and look how much of a better mood you're in. Look at what your reduced stress was. Not even thinking about pain, because the pain was relatively, both of them worked. Look at your stress. Look at how confident you were during the day. And they really couldn't argue with it. Some of them tried to, and they're like, no, just give me a massage, I'm fine. But we had some breakthroughs in our conversations of, they looked at that report and they said, I really think that yoga might be worthwhile to continue, and maybe I, incorporate going to a yoga studio or an app-based program. And to me, that small win was all the win that we needed, because we couldn't say that for everyone, yoga is going to work. But for that person, they got the insight that, like, hey, maybe there's some value in this. And it's not just, stretching and weird breathing and awkward poses. Like, maybe it's something that could help me be better in my life.
Thank you.
You're welcome. Yeah.
Yeah, excellent. Thank you. What was the missingness of Fitbit data? How much? And we have this sort of standard in wearables like actigraph. Okay, at least 10 hours a day is enough. But I think it gets very complex with the Fitbit, especially because often people don't put the watch on when they're leaving the house, unless they leave the house. And I think it also it relates to the degree of engagement with the intervention.
Right.
They're wearing it, so it's just very. I have a lot of colleagues who they think Fitbit studies are activity tracking studies, and it's sort of there's a different element there. And I was just curious if you have thoughts about.
It kind of spans the really gauntlet. With Fitbit in particular, all of our studies, I will say, do incorporate some sort of run-in period where our party line is we evaluate if our studies can fit in with your lifestyle before you kind of commit to the full 12 or the 14 weeks. And so we do have a concept of a valid wear day. For some of our studies, it's actually 12 hours and wearing that we evaluate. Can you demonstrate that you're able to do this for 2 weeks at a time before we actually subject you to all of these interventions? And so that's helped a lot with kind of weeding out some individuals who it's just not going to fit. But with the Fitbit itself, it is being able to catch, is Fitbit not on at all? Or are they just not wearing it? Is it on incorrectly? So we couldn't figure out why we had all of this data, but we didn't have heart rate data. We called the participant and they were just like, yeah, I just threw it in my purse, or I have it in my pocket. Great, don't do that ever again. We didn't specify, but stick it back on your watch. We had issues with Fitbit itself being able, with some of their newer technologies, particularly SpO2, it not reading correctly or it not coming back to our servers for another few days. And so how we're addressing it, if I'm getting to your question, if I'm not, I'm happy to continue trying, is figuring out ways that we can automate the system so that when heart rate isn't detected for, say, a day or several hours, or when no activity has been synced in the last 2 days, right? Because maybe they did all of these things, but they didn't sync it to the system, then send an automated message to that participant and say hey, just checking in, can you sync your device? Are you having issues? And if there's no change, alert the research coordinator so they can give them a call. So all of this being said, didn't say it in the formal presentation, but we thought great, we didn't think we were going to replace research assistants, but we thought our research assistants were going to be being able to handle a lot more work because technology would lift this burden off of them. But in reality, it's just changed the scope of their work to be stalkers of Fitbit data, honestly, and seeing, are we getting what we need? And the minute that we're not, jumping in. And so right now, that's still very burdensome for us. And so we're exploring how do we use technology to potentially relieve some of that.
Yeah, this is very helpful. My question is worried about bias in when the data are missing, because people often choose to not put on the watch until they leave home.
Right.
And if they miss it completely, it might be a day they didn't leave home completely, and that's a big red flag, sedentary day you want to capture.
Right. So completely over my head, honestly, but we do have a paper in the works of different statistical models that are being presented by our N of 1 statisticians in particular, of when are we able to make those estimates and when do we just throw out the data. And for some of our participants, we didn't feel comfortable, with what bias we may be introducing with some of our assumptions. And so their results or their report was, sorry, we don't have enough data at this moment, but we are trying to develop models to account for that. And actually, Ciarán would be a really great person to talk to. I wish she was here today. So feel free to shoot him an email.
Yeah, I will. Thank you.
Anything else? All right, thank you all.